So thank you, Joe. So one of the things that surprised me probably more than anything about our meeting so far is how many of you came back on the second day. And it actually reminds me of that story about George Bernard Shaw and Winston Churchill. And they were great friends, of course, in England. And Shaw had a new play that was opening up in London. And he sent a telegram to Churchill. And it said, "Dear Winston, have new play opening in London, have sent you tickets to attend on the opening night, included 2 tickets so you could bring a friend, should you have one." And Churchill, of course, responded very promptly, sent back a telegram to George. "Dear George, so grateful to you for sending me the tickets to opening night of your play. Unfortunately, have a conflict that evening. I plan to attend on the second day, should there be one." So I thought that I was glad to see there is a second day for us. I should say, by the way, as well, that I too was told that we should discourage any raucous behavior, no loud shouting, no throwing of food or other things at the speakers, no applause, no clapping, no signs of consensus. To that, I would say, the hell with them. We can invite all the National Academy members back into this room to participate in our meeting. Otherwise, I think all displays of emotion should be encouraged. So there's one other thing I would like to do, actually, before launching into the session. Could I have that? So one of the most compelling slides, I thought, from yesterday's very wonderful set of discussions will be up shortly. Here it is. Follow-up studies with and without base. This is actually from Miguel, where he says perhaps a more useful classification than RCT's observational studies. And he noted that every RCT is an observational study on day 2. I thank him very much for that. And then, as if to put me properly in my place, says, "Incidentally, I also wanted a T-shirt, Miguel, if you would kindly." And I expect it to be proudly worn.
Incidentally, I want a new car.
Well, it's good that you're here at the IOM. So just a couple of comments regarding this particular session. And let me begin actually by noting that a number of you actually carried out your assignments yesterday at lunch and captured some of the themes that you thought were really important, and especially I want to focus on those that pertain specifically to this discussion. There were several responses that focused on the idea that individual prediction and prediction at the individual level needs to incorporate more directly biomarkers that characterize the underlying biology of patients, so that biomarker characterization as an important component of prediction. As you know, it's been a key component of efforts in personalized medicine. There was a suggestion that we needed to do more research that informs the pre-treatment risk of individual patients for both benefits and harms. And interestingly, a comment that said that we need methods that do not just anchor prediction at a single point in time when first treatment decision is made, but that is capable of predicting patient's clinical course as it evolves over time. The third comment was carrying on from Mark Latke's presentation, to predict likelihood of responding to treatment A and treatment B to help make choices between them. A very interesting comment that said that given that the methods for prediction are likely to be highly complex, how do we maintain transparency and ensure that the public will have confidence in the results? Which I think is actually a very compelling issue. And finally, and I'll return to this later when we have an opportunity for our summary comments, but there were a number of comments relating to the issue of the importance of better data along with better methods. And there it really spoke to the issue of information that is more granular, more authentic, more reliable. And we might each have a different way of explaining what we mean by those terms, but I think the emphasis on better data is certainly one that we would all embrace. So I would add one other, and that is that we will have an opportunity in this session to discuss prediction models that are driven by efforts to understand the impact of individual variables on prediction, and methods that try to capture the experience of patients, integrated experience of patients as a unit of analysis for their own. And we'll have that, I hope that conversation will be framed in a very direct and easily discussed manner. And actually, I'm confident that it will be. So the session on prediction of individual risk will be led off by Bert Singer, who is currently an adjunct professor in the Emerging Pathogens Institute and the Department of Mathematics at the University of Florida. Before moving to Florida, Bert was the Charles and Marie Robertson Professor of Public and International Affairs at Princeton University. And before that, much to his dismay, he was professor and chair of biostatistics at Yale. I helped recruit him there, and he never forgave me for that. His own research has really centered in three principal areas: the role of social, biological, and environmental risks associated with vector-borne diseases, the integration of psychosocial and biological evidence to characterize pathway to alternative states of health, and health impact assessments associated with economic development projects. He's a member of the National Academy of Sciences and is likely to contribute to the raucous discussion that I hope we will have. So, Dr. Singer.